here's the title of our presentation. And really what we're talking about today is medications and other treatment for Alzheimer's disease, but not necessarily for treatment of Alzheimer's disease, but the other things that come along with it, like agitation, other symptoms that we'll talk about here in a second. So there's some extra stuff in here that I'm going to go through a little bit fast because we want to make sure we get to all the good stuff. But one thing we're going to talk about a lot today is called BPSD. And so what is BPSD? It's behavioral and psychosocial symptoms in dementia. So the most common things are aggression, agitation, psychosis, and mood symptoms, but you can see there's a list of a lot of other things listed below. Other things in there are paranoid behaviors and psychosis, including hallucinations, but verbal and physical aggression. So a lot of the other things that come along with dementia that obviously make life much more difficult. So there are two different algorithms that I've been made aware of for treatment of BPSD. This first one I'm going to call Harvard South Shore. That's just based on the group that ended up producing this algorithm. And we'll talk about it more and in depth as we progress, but here's just an example of their workflow. Another one that we're going to talk about is from the International Psychogeriatrics Association, and they have a similar workflow, and we'll talk about some of the similarities and differences between the two, but also how we incorporate it or we work similar in our clinic. Okay.
In our clinic, we talk a lot about non-pharmacologic interventions for these BPSD, behavioral and psychosocial behaviors of dementia. And so I want to start with that because that's always the hallmark of this work here, even though we're going to talk a lot about medications today because we have a pharmacist. We want you to be well informed on the medications, but we also want to make sure we all understand this collaborative approach between non-pharmacologic and pharmacologic. And so in our office, we're always trying to identify with the caregivers as well as the individual living with dementia what their greatest concern is, what are their barriers to care, how do we connect them with emotional support, how do we provide education around the disease process, what is expected and normal with the disease process, what can we realistically have hopes and expectations around improvement, how do we improve interactions with the care and care partners for this individual, because often those environmental triggers and relationship interactions are a key part in addressing BPSD and connecting care partners with resources in the community, because for care partners to be healthy, happy, informed care partners in their loved one's life, they need support. They can't do it alone. Being connected with resources is essential for respite, community building, and other things. So when non-pharmacologic interventions are insufficient all by themselves, or if we need to de-escalate a crisis while we build the non-pharmacologic supports, we still try to address the lowest effective dose of every medication and optimize its benefit while minimizing risk. And of course, again, always talking about those non-pharm interventions here, environment, caregivers, other disease states.
So regarding medications, here are some different resources that I've used over the years. The three on the right, which are also included on the left, but I think a lot of people are aware of the Beers criteria list of medications that are cautioned in older adults due to increased risk for adverse effects. I really like the next two, deprescribing.org and Sleepwell. Both of these are Canadian websites that do a fantastic job of helping people get on less medicines and understand the risks associated with medicines. So for providers out there, I'd recommend checking out both of those websites. All right, so step one, what medications might contribute to BPSD? So the first step is actually deprescribing or de-escalating therapy. So medications that can make BPSD worse. You see the whole list here. Anticholinergics are always a concern. So medications that are anticholinergic that a lot of people don't think about are a lot of our antihistamines or sleep medicine. So things like Tylenol PM. The PM portion is almost always Benadryl, which can cause a lot of confusion, especially for older patients. I'm not going to go through each of these drug classes, but I do want to emphasize the skeletal muscle relaxants. I don't think there's any drug class that has put more old people on the floor than skeletal muscle relaxants. It causes a lot of confusion, a lot of daytime sleepiness, but I've also seen a huge increase in the prescription of these medications recently, likely to try and avoid prescription of an opioid, but it creates a huge concern for older patients. Antipsychotics is the next one on the list. We actually are going to talk a little bit about prescribing antipsychotics, but antipsychotics could make BPSD worse also. Benzodiazepines, we'll go into that a little bit more later, and you can see kind of the rest of the list here. So if you want to deprescribe a medication and you're not sure how to do it, you can always do a taper. Like there's no rule against not doing a taper. But in general, we recommend considering a taper for any medications that affect the brain. Of course, for benzodiazepines and opioids, you'll want to go even slower. And for benzodiazepines, it could take months or even years before that one is discontinued. But sometimes you're not ever going to get to that point. But in general, a generic taper that we do here is we'll half the dose every 1 to 2 weeks until you get to the lowest commercially available dose. And then at that point, you should be able to discontinue the medication. The person's still nervous about it or something like that, you can always tell them to take it every other day for another week or two, or cut the dose in half for another week or two. But at that point, most people can stop the medication. For sleep medication specifically, one of the tricks that we use is, I shouldn't call it tricks, one of the tools that we use is asking them to cut the tablet in half. They can take the half tablet as they're going to bed. And if they're not asleep in an hour, they can still take the other half. You still are fulfilling, the premise of their prescription, but you're trying to figure out what the lowest effective dose is. And most people that we've come across are quite comfortable with taking these gentle steps into the deprescribing pool. Okay. Medicines can make BPSD worse, but so can some other disease states or situational states. So, here's just a quick list of them: pain, anxiety, depression, agitation. And of course, this is not a complete list. There are a lot of other things that could make agitation, anxiety, different things like that worse. But here, this is just a list of some of the most common ones that we've come across.
So pain certainly can make behavioral psychosocial symptoms of dementia worse. And sometimes it's hard to assess pain, especially if people have become less or nonverbal. Here's a lovely scale that you can use called the Pain Ad Score that helps you determine other ways of assessing pain around breathing, vocalization, body language. So check out the Pain Ad Score if vocalization is becoming increasingly difficult for your patient or loved one. But also, interestingly, in people who are still vocal, sometimes we can overestimate pain's impact on a person's quality of life. Because here's what's tricky. When individuals with dementia progress in their disease state, they have an increased propensity for perseveration, ruminating on things. And pain can be one of those things that they ruminate on. And if we continually help them perseverate on it by asking them every day, what's your pain like today? What's your pain like today? Then suddenly they are having this constant lived experience with pain, and we're over-treating pain. So we want to be thoughtful about under-treating and over-treating pain. So exercise caution when using a pain scale, like asking a person with dementia what their pain is on a scale of 0 to 10. You can still ask, but if they give you the same number every single time, then maybe that raises some alarm that they're not able to accurately understand their pain experience. To further elicit that, I would say, remembering that when we think of our coping skills for anything, be it sadness or pain, we use our frontal lobe, right? And in doing so, we're able to think through complex processes like, I'm having pain right now, but if I just go for a walk, or I call a loved one, or I distract myself, this pain will go away. I won't notice it as much. I won't have as much of a lived experience with this pain. People with dementia lose that ability to have those coping skills, and therefore they're living in the moment, and their pain can be more omnipresent for them, and needing external support to distract them is really important. Here's a case where we saw this happen. This was a 73-year-old woman who, when she came to see us, had been to the ER 22 times in 30 days for pain. She had no diagnosis of dementia at the time, But astutely, one of the ER docs did start to notice some signs and symptoms of cognitive impairment, and so referred her to our clinic, where we then did assess her to have a MoCA of 9 out of 30. Now, some of this cognitive dysfunction on her MoCA may have had to do with her anxiety and her pain and her medications, but there was clearly some underlying major neurocognitive disorder as we got to know her and assess her. These were her medication list. She hadn't been on much higher doses of pain meds in the past, and she was constantly seeking more pain med support from the ER, and it hadn't been changing her experience with pain. And what we came to learn was that what this woman really needed was redirection and distraction around her pain. And once we finally did a lot of education with her, and namely her husband, on how to redirect around pain, her quality of life went up, her trips to the ER went up, her pain medication needs went down dramatically.
Okay, so if we're going to treat pain in our clinic, this is kind of how we go about it. So first of all, we like physical therapy if it's appropriate. If it's not appropriate, then of course skip beyond that. But in our hierarchy of medications, we prefer topicals first, and the topicals are simply, they can provide relief of pain, but they also have a very low risk for side effects. I have listed here diclofenac, lidocaine, and other muscle rubs. If you'll notice, I did not include capsaicin on here. I do not recommend, I believe in capsaicin. I think it can work. I will caution anyone using it in people with dementia, because there's a good chance it could end up in eyes or other orifices and cause a lot of problems. So topicals first. Then the safest medication to take orally would be acetaminophen. And a lot of our patients who we do think have chronic pain will use arthritis strength acetaminophen. I can't explain why it would be better than regular, but a lot of our patients believe it's better, and that's fine with me. So a lot of times we'll use 2 of the arthritis strength twice a day for just standard therapy. Now, I'm going to stop here. I included the rest of the AGS recommendations at the bottom, but anything beyond acetaminophen, even if it's NSAIDs or gabapentin or something like that, you're now greatly increasing the risk for adverse effects. And so it doesn't mean you can't use it, but we just caution. And so we always want to emphasize these first 3 before we move on to something more dangerous. Okay, other than pain, there are other disease states that can exacerbate BPSD. Notice with the first category of brain fog. So often with dementia, the person will recognize there's something wrong, but they don't know how to describe it, or maybe they've lost the vocabulary on how to describe it. When they come to see us, they might say, I'm dizzy all the time, or I'm nauseous. And what we have learned is that they might be, or they might not be. It might be that they just don't know how to explain it, and we need to ask more questions or make more observations to figure out how do we best treat this person. Because if we prescribe a bunch of medicines to help treat something that's not really there, we could actually make things worse.
Yeah, an example, right, is we hear this dizziness and brain fog, and first maybe they present with dizziness, they say it's dizziness, and we see that they've been prescribed a medicine like meclizine from an outside provider, and that actually increases their increased risk of falls and worsens their confusion. And when you get to them talking more about the dizziness, then they say, well, we've had this happen many times, where they say, well, it's more of a brain fog, it's a confusion. And then that's getting to the underlying baseline cognitive impairment that they're experiencing that no meclizine is ever going to resolve.
Yeah.
But obviously you want to work up the dizziness for other things like orthostasis or medications that contribute to dizziness.
The next one is, it's common with a lot of people with dementia, is anxiety and agitation. So you could have that baseline, but some people, there's triggers around. And unfortunately, sometimes it's the caregiver who might be the trigger for the person. But it's identifying what are the triggers that could be making those symptoms worse. So large life events could also be part of the problem. So we had one patient who had stopped showering and she stopped taking her medications. She was overall much more agitated, and the family was at their wits' end. What are we going to do? Well, we found out that the son's girlfriend and her dog had recently moved into the house, and that was probably setting things off. We had another patient whose daughter called and was like, we just met with you guys 2 weeks ago. The world is falling down. She's not taking care of herself. She's up all night vacuuming. Like, what is going on? And I'm like, there's got to be something else that we didn't. I mean, the medication we changed shouldn't have done this. And then the more we asked, we found out that the woman's best friend had died a week before, and they were about to go to the funeral. and the daughter had just overlooked that kind of stuff. So should we give her a medicine to treat something that might not cause her hardship for a long time? Most people would say no, but every once in a while you should. So I'm not saying you shouldn't, but we might be able to find other things that could be corrected to help make things better. Another thing, and is loneliness. The lack of social engagement for a lot of people becomes a real burden. And we see a lot of people, I mean, we've had multiple people say, I'm scared at night. And so having someone come and stay with them or even going to a facility makes things better because now they're around more people.
The trick here is, if a person who is not living with cognitive impairment has an experience like a new roommate move into their house and now they have increased stress, or they lose a loved one and they're going to a funeral, they may say, yes, there's been a change in me. I don't need a medicine to solve this. I need support or other things, and they can seek those out. When a person has cognitive impairment and they have less ability to express those things, they have well-intentioned care partners who are trying to support them and are taking care of the issue in the moment, but maybe lose sight of the greater context. And so we just want to encourage you all to continue to advocate for understanding the greater context and always asking those questions. Here is a classic example of that. This is a lovely patient we had, an 82-year-old woman who was having delusions of parasitosis. So this is where she believed that little white flecks of lint on her coat and her shirt and her clothes were bugs. And she was constantly fixated on having bugs. When she was at her highest peak of symptoms that were distressing to her, she was having a lot of skin picking and mild cellulitis type infections because of her picking at her skin and this concern for bugs. She had been treated for years prior to coming to see us and was on this regimen when she came to see us. Instead of escalating any of her regimens, we worked with her and her son on, again, distraction and redirection. We were not able to deprescribe any of these medications, but avoided further escalation. Her symptoms remained kind of omnipresent. They were always there for years while we were seeing her, but she was no longer picking and causing skin infections like she had been when we first saw her. But she still would come in each time and tell us about the bugs and that they were there, and she'd kind of come to live with them. Interestingly, on one visit she came in and she, after many conversations with her son, had decided to move into an assisted living facility. When our nurse practitioner asked her why she moved into that facility, she said, I realized I was sitting around all day and watching television, and I figured that can't be good for me. And sure enough, she was right. And despite many people trying to convince her that she should consider moving, she wasn't interested. But one day she decided for herself that she should move, and she did. And from then on, our visits with her, there was no more discussion about bugs. Just having social engagement. She started going to the gym, having meals with other people. She was no longer lonely, and she was no longer even observing these bugs that had plagued her for so long. This was not a woman with major neurocognitive disorder. She had a primary diagnosis of parasitosis, but I think this is important because it has to do with the medications that we routinely see prescribed in these situations.
Okay. The next step after kind of these baseline therapies and figuring out do we have our bases covered are the medications for Alzheimer's dementia optimized? And both algorithms have this part. So I'm going to go through this part really fast. But essentially, there's 3 different classes of medications that are used for treatment of Alzheimer's. We're going to talk about these 2, the cholinesterase inhibitor and memantine. We're not going to talk about the third most recent class, the injectable monoclonal antibodies. They don't have a role here. But basically, the recommendation is to optimize these or at least try them out. And I'm just for the sake of time, I'm going to have to rush through this part real quick. But I do recommend that if you're going to start these out, number 1, to make sure you separate administration or starting these 2 medications by about a month. And the reason for that is there are side effects associated with them, especially the cholinesterase inhibitors. And if you start them both at the same time, you don't know which one was the problem. But our next slide kind of gives us an example of some of the side effects that you can see. So this is LM, 79-year-old female, presumed Alzheimer's dementia. Mocha, 16/30 in December of 2023. When she came to us, she was on this regimen that you see here before. We might have started the sertraline, but I believe she was on all these medications when she came to us. She has a long history of anxiety and agitation, which had gotten worse recently. She even had taken diazepam at bedtime for a while. But she was, in September of 2024, it was reported that it was difficult to get her to take her medication. She was refusing to take them. And then at that visit, she said she wanted to stop all of her medications. Just before that, she had been struggling with a lot of anxiety and agitation, also bowel incontinence. And these had over years waxed and waned, but they had just finished waxing. And so she was like, it's the medicines, it's the medicines. And so we gave her instructions on how to stop the donepezil over about 2 weeks. After we did that, I didn't hear from them for a long time. And then in January of this year, her husband called and said, why isn't she on donepezil? And we explained, do you remember this? And he's like, oh, that's right. And he goes, and you know what? She was wandering around the house. She found an old bottle of donepezil and she wanted to know why she wasn't taking it. So I thought, good question. So that's why I called you. But he goes, now that you mention it, she hasn't had any diarrhea now. And she's not as agitated as she was before. And so where I'm going with this is, when we say optimize these medications, especially for Alzheimer's, like the cholinesterase inhibitors and memantine, it doesn't mean turn them on, dial them up to max, and then just keep them on it. It means start the medications and then get feedback from the patient and the family to see, are they having side effects? Is life any better? Is this providing benefit or at least not causing harm before we move on to the next step? So the next part is the pharmacotherapy for anxiety and agitation optimized. So most support for use for citalopram comes from the CIT-AD trial, which found that citalopram 30 milligrams daily improved BPSD in non-depressed outpatients with Alzheimer's dementia. However, since then, the FDA has reduced the recommended max dose to 20 milligrams daily in those greater than 65 years of age, which has led other people to wonder, should we even be using citalopram? And the jury's out on that. Most people think it's safe to use, but a lot of people started using S-citalopram. So can we use S-citalopram? Well, there was no great big study that looked at its use in BPSD, but the experts by and large at this point think, well, it's a suitable alternative. And essentially 10 milligrams of citalopram is equal to about 5 milligrams of S-citalopram. So if you want to get to that CIT-AD trial of 30, you'd probably need about 15 milligrams of S-citalopram. So we do think that this is a sufficient or an acceptable alternative to citalopram. It does seem to provide good relief. In one study that wasn't looking at BPSD, but was looking at anxiety and agitation, they found that people got best benefit when you went to S-citalopram 20. So we start at 5, we'll titrate it over time. It's okay to go up to 20 milligrams daily on that medication.
However, there is increased risk of falls and QTC prolongation at doses above 10, so you want to screen for those things closely.
Yeah. And the QTC prolongation is not as bad as it was with citalopram, though, so you might come across that. But go ahead and go to the next slide. So then there's one other SSRI that's been recommended, and this is sertraline. There's no QT concern here, so this is a good alternative too. And so usually we start at 25 milligrams daily, and we'll titrate from there. A 2011 Cochrane review concluded that sertraline was efficacious for BPSD symptoms.
We use these medications a lot in our clinic. Sertraline and escitalopram are sort of our first line go-to medications for helping with behavioral and psychosocial symptoms of dementia.
Yeah. There's a lot of other SSRIs that exist. The Harvard algorithm specifically states that the other SSRIs are not well studied, but also have a lot of drug interactions. So we really don't consider those three. This next part, SSRI alternatives is what I'm calling it, is not in either algorithm, but it's something that we do in our clinic, and I think it makes sense to bring up. So SNRIs, so duloxetine and venlafaxine tend to be the most common ones. We usually use duloxetine because it's easier to stop if we need to than venlafaxine. But we'll consider these for people who have pain, especially neuropathic pain or back pain. So there's evidence that these medications can help with both anxiety, agitation, depression, and pain, those types of pain that I just described. And so it doesn't have as robust of evidence for benefit as the other ones we just mentioned. But if we can help with pain too, then this makes sense. Another one here is buspirone. Buspirone has been shown to be beneficial for older adults who have generalized anxiety disorder. It hasn't been extensively studied in those with dementia, but it has a low side effects profile, so it's generally considered safe and an acceptable alternative. One of the problems with buspirone and why we might not use it that often is it has to be dosed multiple times per day. So that makes it difficult for some of the regimens that people use. The last one I have listed here is mirtazapine. Oftentimes we will use this for people who struggle with anxiety, especially if it makes it difficult to fall asleep at night. There's not a lot of good evidence that this can help with BPSD also, but it does have evidence to help with older adults, including with treatment of anxiety. We'll start with 7.5 milligrams nightly, and if we need to, we'll go up to 15. We generally don't go higher than 15 milligrams. Doses higher than 15 milligrams for mirtazapine tend to be a little bit better for treatment for depression than for anxiety, and that's a lot of times what we're dealing with when we start that medication. Okay. Are there any medications that can be used for sleep? This is the question I think we get asked in this clinic more than any other question we get asked. So in our clinic, I guess one thing I want to point out is circadian agitation might also be often referred to as like sundowning. So I've included our biggest concerns right here for sleep medications. And really, they are all quite valid. We've seen it in a lot of different patients, but especially confusion and falls. I've included on the side here this Sleepwell website. Please go check out sleepwell.ca. This is a great website that helps. It's for providers, patients, caregivers to help them understand, all of us understand the risks associated with sleep medications, alternatives that we can use, and how we can sleep better, but with less medicine.
Yeah, so yes, people need sleep to not have behavioral and psychosocial symptoms of dementia, but also we want them to have good sleep without meds if and when possible. So what is behind lack of sleep?
So there's a lot of different things, to be honest. So poor sleep hygiene, napping during the day. What happens is when someone comes in and they express concerns for sleep, we ask a lot of different questions. And then we try and target what those specific things are instead of just sleep in general. And one thing I want to mention is the stimulating activities before bed. I mean, this is one that comes up quite often, and it can be even just watching the news anymore. It could be stimulating activity or movies or sports or something like that. So it's trying to figure out what's going on and how can we make that better. And we have some examples, I think, on the next couple slides.
Yeah, so again, you want to understand their baseline situation. Is the insomnia new? So if somebody comes in and says, we need something right now for mom's sleep, and then you discover that mom has had difficulty with sleep, fragmented sleep most of her life, you're not suddenly going to fix that overnight, and certainly not in the setting of dementia suddenly. So having a sense of the chronicity of it, not that it doesn't matter, it does, but it kind of changes your sense of urgency and allows you to recognize you have more time to address sleep hygiene, which can take time, but maybe reduces some of your urgency to feel like you need to feel compelled to prescribe something today to address this issue. Also understanding how many hours of sleep are they getting and what is their expectation around how many hours of sleep they should be getting. Many people get and only need 7 to 8 hours of sleep at night. And not always do those hours happen consecutively. So it's okay if they're sleeping some amount of hours, have some wakefulness, and then get more hours of sleep. I'll give you an example of this. We had a patient who was recently moved into a facility. She was here, had a diagnosis of dementia. She was seeing our clinic with her 3 adult children that were all very concerned about her new experience in her environment that she was living in. And they said the one thing that they wanted to do was get a medication to help her sleep because the staff were telling them that she was up all night walking around. We said, great, let's gather more information first. Let's find out when she's going to bed how long she's sleeping, when she's actually up, if she's going back to sleep, and if she's napping during the day. We'll come to find out she was napping some during the day, but not a terrible amount. But mostly she was going to bed at 7 p.m. She was sleeping 4 hours, then she was up for 2 to 3 hours, then she was going back to sleep and sleeping for another 4 hours. So she was getting 8 hours of sleep. She had 2 to 3 hours of wakefulness at night. And we also learned that she's going to bed way earlier than she used to, which might have been contributing to her wakefulness in the middle of the night. So we asked the family, do you feel like mom needs a medication to help her sleep more than that? And they recognize that certainly no. She's getting adequate sleep, and she's in a facility where she's safe to be wandering around for 2 to 3 hours at night. So while it might not be convenient, it's safe. There's nothing wrong with that. And we can try and compress that amount of time that she's awake at night by helping her not to go to bed so early. So just an example of how asking questions and setting expectations around sleep can help reduce risky medications. So we do everything we can to avoid prescribing for sleep, like we talked about, understanding expectations around sleep, timing, sleep hygiene. Again, there are books written on this around a cool, dark environment, maybe some white noise, avoiding screen time before bed, avoiding certain beverages and foods before bed, setting expectations, addressing disrupted sleep-wake cycle, which is a whole talk in and of itself, trying light therapy if they do have disrupted sleep-wake cycle. And then when you try all those things and they don't work, our first go-to for a medication would be melatonin, as we consider this to be the safest of the options out there. And we start quite low. I recommend a max dose of 10. You can start with a dose of 3, and if they're still awake after a couple hours, try another 3. Anything else you want to say about that, Jeremy?
So melatonin is not on either of the algorithms, but we do include it here because we find that its side effects profile is so low that we'd like to start here in case there's some people that it does work for. And I will say that there are some people we tried it, it does no difference, and so we end up stopping it. But if it works for someone, this would be the safer alternative.
And sometimes it's a placebo effect, and if it's a placebo effect, you're after sometimes something like a low dose Tylenol before bed can serve that need as well. And there are some studies that show actually scheduled Tylenol before bed does reduce sleep disturbance and improves with BPSD in people with dementia.
Okay, so both algorithms do include trazodone, or is it trazodone? So here is both. So one algorithm said trazodone is commonly used or may be tried. Like that's like their evidence for benefit. The other one said it's known for its sedating properties. Like even like Cochrane, like the best they found was in 2020, they said identified one trial with 30 participants who had moderate to severe Alzheimer's dementia. And the conclusion was low certainty that it might improve sleep time. I don't know how trazodone became the default, like this is the sleep med we go to, but it has, and I'd like to like kind of dispel some of the myths around it. So I'm not confident in trazodone. I have concerns that it can affect cognition, and I have concerns that it can increase the risk for falls, both of which has been shown to happen. So in our opinion, we avoid trazodone if possible for the concerns I just mentioned. For those who are on trazodone, we attempt a taper and try and stop it. We're not aggressive with it, but we try and make those steps. And ultimately, trazodone might be worth trying. But we recommend to exercise caution and not just assume it to be as safe as any other antidepressant. One last thing I wanted to mention was if you look at the doses of trazodone here, the recommended dose is 12.5 to 25 milligrams. That's a quarter to a half of a tablet. That's the smallest dose that you can get of trazodone. So we don't need to have people on 100 milligrams or 150 milligrams for sleep at nights. If you get to like 50 and you haven't got any benefit yet, you're probably not going to get benefit with trazodone.
You're just going to have more side effects.
True. Okay, here's the next one. So the dual orexin receptor antagonist. So you might know suvorexant or Belsomra and Dayvigo. So I'm just going to call it Belsomra to make it go faster and smoother here. But one algorithm recommends this. The other one does not mention it. But it does. So the International Psychogeriatrics paper references this paper right here. So I went and I grabbed the data from it. And first of all, I'm just going to say I have multiple concerns with this study. So this is what was used to say, yes, Belsomra should be used for those with dementia. So first, it was used in those with, quote, probable Alzheimer's dementia with an MMSE score between 12 and 26. So that's a pretty big range. And then second, they use what's called polysomnography to gather a lot of data, which is good. But I don't know many dementia patients who struggle with sleep at night who could tolerate the invasive testing of polysomnography. If we look at this chart here, another reason why I'm skeptical is, number one, most of our patients are older, but if you see the older patients, it didn't favor either placebo or Belsomra. For those with worse dementia, so defined by moderate score on their MMSE, it didn't seem to favor either one. And those with ApoE4 genotype, which tends to be people who have Alzheimer's dementia, it didn't favor either one. So I don't know exactly who they tricked, but somehow they got their name in there. Here's just an example. So we met this patient many years ago in our clinic, but she's a 75-year-old female. She was treated by psychiatry. You can see her list of medications there. When we first met her in August of 2018, her MoCA score was 20/30. In November, we had a talk about it. She was taking the suvorexant 10 milligrams nightly. She was sleeping about 10 hours per night. And during our visit, she was noticeably sedated and confused. We talked about reducing the dose, and she was agreeable. So by December, she was down to 5 milligrams nightly. She realized that she had been struggling to function during the day, was doing better on the lower dose.
And of note, back in November when she saw us, she was concerned she had dementia, as was her family.
Yeah, that's true.
And that was the reason for the visit.
Yeah. So she was no longer napping during the day. So suvorexant or any of these sleep medications, they don't automatically leave the body when you wake up in the morning. And a lot of times they hang around and they cause sedation and fatigue during the day. By January 2018, she had stopped suvorexant. So at that time, she had been off for about a month. So we rechecked her MoCA. And at that time, she was 25/30. She mentioned she was much more awake during the day and more engaged in life. And by March, she had no more concerns about her sleep at night.
Or her cognition.
So we've talked a little about sleep, and I'm sorry I didn't have any great answers for people regarding sleep medicine that can cure all. But let's talk about medications for severe symptoms.
Of BPSD.
Of BPSD, right. Sorry, we're moving on from sleep here. So these are the two algorithms that we mentioned. So the Harvard Health Short and the International Psychogeriatric Association. So if you notice, first of all, first line for moderate to severe agitation, they have antipsychotics listed. It's kind of a similar list, but not exactly the same. Then they have kind of a different order there, but they have prazosin or antiepileptics. So that's how they kind of compare. What I'm going to walk you through next is a few thoughts from our clinic, but also how we practice in our clinic. So one thing I want to talk about here and take just a break from the whole talk is brexpiprazole, which is on the International Psychogeriatric Association recommended list of antipsychotics.
And you see it under number 1 from International Psychogeriatric Association.
Yeah, so this is also called Rexulti. And it's not on the Harvard South Shore one, probably because it was published before it got an approval. But Rexulti, or brexpiprazole, this is an antipsychotic that now has FDA approval for treatment of agitation in Alzheimer's disease patients. You've probably seen the commercials. You've probably had drug reps come to your office. And if you haven't seen it, I guarantee you your patients and their families have seen it. So let's talk about this real quick. So a journal article was published in 2024 that summarized the studies that were used to get the FDA approval for treatment of agitation associated with dementia due to Alzheimer's disease. These studies compared brexpiprazole to placebo, not to other antipsychotics or even SSRIs or other therapies that are typically recommended. And then the evidence for benefits was the improved agitation scores. One thing to note is that doses less than 2 milligrams of brexpiprazole were not shown to be any different than placebo. So that's why they kind of have 2 or 3 milligrams listed here. Here's a list of the side effects. I'm sorry, I'm going to go through this really fast, but
they are somnolence,
so
nasopharyngitis, dizziness, aesthesias, diarrhea, urinary tract infections.
And really the main one was somnolence, which really was not a very high risk. It was only 3.5% of people, but that was the most common one. But let's get to this part. So there was a higher mortality rate of brexpiprazole in the treatment group, 0.9% for brexpiprazole versus 0.3% for placebo. So the Rexulti Rex have taken this 0.9% mortality rates over a period of about 2 weeks and touted it to be safer than other antipsychotics. But is it? Well, they took this chart from a Cochrane review and decided to throw their brexpiprazole data in it. I'm going to go to one more page here. So I find this to be the most manipulative representation of the data. So they basically took the 1, 2, 3, 4 antipsychotics on the right that were reviewed by the Cochrane review and just added their stuff in there, which is not appropriate. This is not recommended. Please don't do this.
They were not head-to-head trials. Right?
Yep. And the main thing that you can see that makes this not a head-to-head trial is look at the placebo mortality rate. For the brexpiprazole group, it's 0.3%, but for all the others, it's around 2%. This implies that, number one, they probably looked at people over a longer period of time for these other antipsychotics, or maybe they had more severe disease states. We're definitely not comparing apples to apples here. But if you want to do a comparison, because I mean, they started the fight, so let's go ahead and look at it. What you do is you look at the relative risk. And so relative risk is how much more dangerous is it to take the medication than to take placebo. The higher the number, the more dangerous it is. And when you do that, you actually see that brexpiprazole has a relative risk of 3, which is higher than any of the others. Well, that was awkward. So beyond that, the journal article also makes several threatening statements about how now that it has FDA approval, you should use this because you could get sued if you don't use brexpiprazole or Rexulti and different things like that, which I thought was not a good form. So the article conclusions for brexpiprazole or Rexulti is that it's FDA approved for reduction in agitation in the setting of Alzheimer's dementia. Doses less than 2 milligrams don't seem to be effective. That would be the things that I would take. Additional pharmacist thoughts are that FDA approval does not mean that it's more effective than other traditional therapies like SSRIs. You can think of it actually similar to aripiprazole in the way that it affects the brain. And we do not know if it's better than other antipsychotics because they did not compare it to others. And so it's too soon to say if it's any less risky. And one thing I do know is that it's extremely expensive, and I've seen it prescribed for people, and I've yet to see someone on it due to cost. So in our clinic, here's what we do. First of all, ensure that non-pharmacologic interventions have been optimized. And then?
Yeah, and so as you heard, we're not using Rexulti in our clinic for the reasons Jeremy mentioned. So we stick with the oldie but goodies in terms of those that have more evidence. Risperidone has evidence that supports efficacy that is as good or better than the other antipsychotics available. Its evidence is about equivalent to that of aripiprazole. It does have a lower fracture risk associated with it. It is affordable. It's well known. And so we start with this one at a low dose, 0.2 milligrams to 0.5 milligrams daily, usually starting at night or around when they're having behavioral psychosocial symptoms of dementia that are not otherwise managed by non-pharmacologic interventions. You may increase by 0.25 milligrams daily. We go to a max of 2 milligrams daily. Adequate trial time is about 3 weeks. You should see effect relatively soon, and it is less sedating than other antipsychotics. You'll see us more often use an antipsychotic like risperidone in the setting of what we call acute crisis. So that's when a family comes in with their loved one and they say, boy, things were fine for a while, but in the last coming months, there's been an increased experience with agitation where I'm routinely trying to keep them from not trying to run away or yelling, throwing things where there is harm to oneself or others in not a homicidal way, but in a just kind of physical or very verbally violent way. And we're trying to help with that acute crisis and de-escalate that acute crisis. So then once we get that acute crisis under control, we can start medications that we think are safer for the long term, like those SSRIs we mentioned earlier, and then really diving into the education and support around the non-pharmacologic interventions. So again, it's like if a person's seeing you for the first time and they just need acute crisis support, this might be a good place to start, but the key hallmark is see them back frequently, work on implementing those non-pharmacologic interventions that take time, and start those medications like SSRIs that take more time to take effect and notice improvement. And then work on deprescribing the antipsychotic that was started in the acute crisis.
So aripiprazole would also be an equally, according to all statistics, equally appropriate antipsychotic. It just is not the one that we use. We have had patients come in on aripiprazole. We don't stop it. We will maintain it. Our goal is always lowest effective dose, though. Prazosin is another option. This is an alpha-1 blocker. So this is using a mechanism of action that we haven't talked about yet. So it could be effective compared to the other medications. We've never used it in our clinic. Our biggest concern would be orthostatic hypotension and dizziness, because alpha-1 receptors are also in our vessels, and so it can drop blood pressure, but it is appropriate to use. Other ones to use would be mood-stabilizing anticonvulsants, gabapentin and carbamazepine. They are way down at the bottom of the list for most algorithms because their evidence for benefit is not very good. And then I also included a couple other ones down here at the bottom that are not recommended, although you might see some people on them sometimes because at one point or another, we kind of thought that they might help. I'm going to move on to, we're running out of time. So
yeah, I'll just say briefly this case really quick. A 60-year-old gentleman that came in with diagnosis of FTD, frontotemporal dementia versus Alzheimer's disease. They actually were not concerned about behavioral psychosocial symptoms of dementia, but were concerned about mobility. He had, however, had a significant history of BPSD and in the past, which had been treated with the following regimen listed here. Our concern was that these medications were now causing his mobility concerns and his significant decline in cognition that his wife was noticing. But his behaviors were, according to her, quite controlled. What we learned was that they were RVers. They traveled around in an RV all the time. And whenever they would travel from place to place, they would have an escalation of behaviors. They would reach out to their provider over the phone or through MyChart, and there would be an escalation of dose or a new medication added remotely. And so we had a pretty lengthy heart-to-heart about maybe it was time to set up a stable home where we weren't traveling, which as that was a key trigger. And we were able to ultimately help deprescribe some of these medications.
Okay. I just want to mention one last thing. What is not in the algorithms? So these are medications that I often see get prescribed for people for treatment of the symptoms associated with BPSD, associated with dementia. And I just want to emphasize, these are not on any algorithms. It doesn't mean you can't use them, but I would not reach for them first above other things. And so we have antihistamines, so things like Atarax, hydroxyzine, benzodiazepines. One thing I will say is if a person has been on benzodiazepine for a long time, there was one recent study that suggested there could be increased death if it gets stopped. So we will encourage your dose reduction of benzodiazepines, but we're not aggressive with stopping it. But we also do not recommend starting it in people to help with agitation associated with BPSD. Skeletal muscle relaxants, TCAs. One other thing that I also want to mention that I forgot to earlier was on the list of antipsychotics that are used for agitation, one that you might have noticed wasn't there was quetiapine, Seroquel. This is probably the antipsychotic that I see get prescribed the most, but it's not recommended because it just didn't seem to improve symptoms for BPSD. We will use it here for people with Parkinson's disease or Lewy body dementia who have hallucinations because it has the least amount of effect on dopamine receptors, but we do not use it for BPSD in general. Key points. Main thing I want you guys to take away is that algorithms exist to help guide the treatment of BPSD. So on the next page, there's references, and that can help guide you to the two different algorithms that I mentioned. Next thing is before adding medicines, please look for other causes of BPSD, whether it's medications, undertreated disease states, or triggers that could exist. And then last thing is all medications carry risk. So like we say here a lot, lowest effective dose of every medicine, and just make sure you get feedback from people and from the patients and from the caregivers to know that the therapy is the best for the patient. And I think we made it to the end.
Yeah, so we have got 5 minutes for questions.
Jeremy and Kara, thank you so much. We did have a question about referral process, but I'd like to email you separately to get that answered. If we have medication specific questions, let's leave time for that here.
I have a question.
Thanks.
Yeah, it's not necessarily about the medications itself, but more of the non-pharmacologic things. What is the data? Have you guys used light boxes for people to help with the kind of day-night regulation before? Do you have the data on that? I'm not super familiar with that, but I've had other people ask me about that.
Yeah, so we do recommend bright light therapy specifically for disrupted sleep-wake cycle. I can't quote the data for you off the top of my head, but we have a handout that's been generated by our geriatric psychiatrist, Dr. Ablash Desai, that has the data listed on it and the specific LUTs that you need, the amount of light therapy and the timing and durations. Joelle, I can email that to you, and I'd share that with Lindsay, and she can share it broadly with this group here as part of the follow-up to this. But yes, so we specifically use it for disrupted sleep-wake cycle. So for others listening here, that's when someone is awake at night and sleeping during the day. That takes we tell families it's going to take a very invested caregiver to keep that person awake during the day. Obviously, you want to use the light box in the morning in the first 30 minutes of the day. You can use it again around noon, so you can use it twice in a day. And then you want to keep them active and busy during the day and really try and get them to avoid falling asleep, and they're more tuckered out and ready to sleep the next night. But it takes an intensive effort from the caregiver to keep them awake in addition to the light therapy.
Perfect. Thank you.
Yes. Great question. Other questions?
We have one in the chat. Since over-the-counter supplements like melatonin are not FDA regulated, do you have specific brands that are reliable or brands to avoid?
The main thing I tell people is there is a label that you can look for called USP, and USP is an independent lab, and so these the manufacturers that want the USP label will send off their product to have it tested, and then if it's what's in there is what's in there, then they can put the USP label on it. So that would be number one, but I've also noticed a lot of brands not using it anymore. So I would just recommend looking for one that would want its reputation to not be tarnished. So I would not go with something that's, I don't know how to explain it, but you want to just look for something that looks like it would be reputable or something like that. There's a lot of other ones that, they could make a short supply of something and then just disappear, and it looks like a very generic bottle, and they don't care if what's in there is not what they say is in there.
We see Dr. Melchiorria has a question about ordering PRNs for BPSD. We do see that request often, especially for individuals living in facilities or from family members that say, occasionally they're just, when they have these episodes of being more agitated, is there something you can give me to give to them in that moment? And so my suggestion around this is if you're going to offer a PRN, make sure you do it with close follow-up so that you can assess how is it helping, how often are you using it, and in what situations are you using it, so that you can identify if there are triggers during those times that are causing the use of the PRN such that you could avoid the trigger. So yes, we do periodically order a PRN, but with close follow-up and questioning, and it's an opportunity to learn. So say if you're going to use this, we want you to closely document what is being observed around the use of this, and can we therefore change that thing, the trigger, instead of continuing with the PRN. But if there's no non-pharmacologic interventions that can fix the need for that PRN, and the PRN is being routinely used, then maybe we address the underlying maintenance therapies as well. Anything else you'd say to that?
No, that's good.
Great.
Using caution and close monitoring.
Thank you. Kara, I'll follow up to get that resource. As a reminder, all of our resources, I put the link in the chat here so that you can always go back there to gather those. So thank you everyone for all of your questions, and Kara and Jeremy, great information. We appreciate you. We're going to come back again May 27th from 12:30 to 1:30. Audie is our presenter for that session, and the topic is managing cognitive health in primary care, early detection and intervention. So we hope to see you May 27th.